Well, that's a terrific question. That's an excellent question. And again, hopefully with this renewed interest, there'll be more opportunities for research and studying these kinds of questions. The evidence from the past suggests that if you can recognize it early on and stop the antipsychotic drug, the chances of it going away are increased, are greater. So it is possible if you, and doctors should routinely, regularly assess their patients and question their patients for any signs of emerging side effects, including these movement disorders, because again, if you can pick it up early and it's possible and safe to stop the antipsychotic drug, there's a better chance that the dyskinesia may go away. Early tardive dyskinesia, or so-called withdrawal dyskinesia, has a better prognosis. It appears that that's more likely to go away. Whereas if the tardive dyskinesia or the dyskinesia exists for months or years, the chances of recovery are much, much less. So it is incumbent on doctors to, again, learn what tardive dyskinesia looks like, to monitor their patients regularly and to question them and to educate them to, just as people do regular skin exams or breast exams to pick up pathology, patients on antipsychotic drugs should be educated about this side effect, and they themselves watch for any signs of twitches or movements and report it to the doctor, because they have a better chance of recovery. And so that's apart from the new drugs, which may be more, which are more appropriate for someone who has established persistent tardive dyskinesia. But so besides that, I think educating doctors and patients about this phenomenon and how to recognize it, how to manage the antipsychotics and so forth, is very important, even apart from the new drugs. And the other issue you touch upon is, unfortunately, there are patients who have chronic psychotic disorders like schizophrenia, for whom stopping their antipsychotic treatment is potentially hazardous, and they could have a relapse and become psychotic. So in those cases, there are potentially other things to do, and as you mentioned, possibly switching the medication to something with a lower risk of causing tardive dyskinesia, changing the dose. These are all options that need further study, but are very important for doctors to consider. And beyond that, as you might imagine, it's very important when tardive dyskinesia is detected to have a sit-down with the patients and their caregivers to discuss this and discuss the various options. It's important to rule out other disorders that may cause dyskinesias. There's a differential diagnosis, so when someone develops a movement disorder, it's not necessarily tardive dyskinesia due to the drugs, so you do have to consider Huntington's disease and Wilson's disease and other drugs the patient may be taking to rule that out. And then if in the end they have persistent tardive dyskinesia, you've changed the antipsychotic the best you can, and the dyskinesia, the movement disorder, is still bothersome, then these new drugs like valbenazine could be tremendously helpful in suppressing the symptoms of tardive dyskinesia to enable the patients to live a more normal life. Yes, that's a very good question, and I like to say, in the end, you have to be a doctor. I mean, this is not about simply prescribing pills or anything like that. And being a doctor means evaluating the history, the physical exam, laboratory studies, potentially imaging studies, and formulating a differential diagnosis of all the possible causes of the symptoms that the person has. So this goes for any problem in medicine, and it's true here as well. When you see someone with dyskinesia, your doctor alarm has to go off, and you have to consider the differential diagnosis. And as always, it's based on a history, on family history, on a physical exam, on laboratory tests or imaging, and if you're uncertain, as a psychiatrist, if you're uncertain, if it's an unusual case, if it's atypical in some way, for example, if it came on very suddenly, if it progresses rapidly, if there are other neurologic signs or systemic signs of illness, if there's a family history of movement disorders, these are all clues to other disorders that could mimic tardive dyskinesia. But in the end, again, as a psychiatrist, if you're not sure, then it would be a great idea to consult your neurologist colleagues to have a more in-depth evaluation, including potential genetic testing, to decide what the diagnosis is. But that's a very important part of the evaluation and management of someone with new onset movement disorders. Excellent. Another excellent question. Has been, at least in the past, a great deal of research to try to identify who might be at risk because it's so important. And a number of things have fallen out of that. For example, age is probably the strongest predictive risk factor for tardive dyskinesia. So older people have a 5 or 6 times greater risk of developing tardive dyskinesia on these drugs than younger patients. So it's even more critical than in the elderly and older population to make sure the indications for the drugs are proper. So age is probably the strongest predictor of tardive dyskinesia. There's mixed evidence on other factors like gender, like women, older women, intermittent treatment. So surprisingly, if people have been treated on and off antipsychotics rather than taking consistent doses of antipsychotics, they're actually at more risks. It's sort of counterintuitive. You would think someone who continued to take the drug might be at greater risk, but studies have found that actually it's the people who go on and off the drugs who seemingly have a greater risk of tardive dyskinesia, potentially race or ethnic origin. There have been some differences, although a lot of these other factors are confounded by other things, how the antipsychotic drugs are used, again, intermittent treatment, higher doses, more potent drugs, more of the older, more potent dopamine blocking drugs. Those are all risk factors that have been considered, although the evidence is not always cut and dry. Well, again, I'm very excited. For me, I've always been interested in this area, and I've always felt that we had an obligation as physicians to do something about tardive dyskinesia, since this is a drug-induced iatrogenic disorder, unfortunately, that occurs as a result of necessary treatment. It's very important to emphasize that these antipsychotic drugs are critical and highly effective drugs. We can't lose sight of that fact, that people's lives have been saved and because of the antipsychotic effects of these drugs. They're highly effective for schizophrenia and other psychotic disorders. But unfortunately, there's been this chronic, stigmatizing, sometimes disabling neurologic effect. So it's really a long time coming, but I think because of the hope of these new drugs that offer treatment, we're going to, rekindle interest in tardive dyskinesia and helping the people who have it, as I said before, to live a normal, psychotic-free and tardive dyskinesia-free existence.